Good afternoon, everybody. Today, we are going to talk about liver disease during COVID pandemic. We all know that COVID-19 primarily affects the lungs, and we are always talking about the mechanism, the mortality, and the morbidity associated with lung component of the COVID disease. While lung, no doubt, is an important and a very important component of COVID-19, we must realize that over the last 1 year, we have also noted manifestations of COVID in other organs, and we are today going to talk about liver disease and COVID. This will be the agenda of my talk. I'll talk to you about liver dysfunction during COVID infection, what happens to pre-existing liver disease if somebody has COVID. We will touch upon some of the aspects related to liver transplantation and vaccination in liver disease patients. So when you talk about COVID-associated liver injury, we have to understand that it can be the effect of direct cytopathic effect of COVID virus. There can be a cytokine release syndrome affecting the liver. There may be dysregulated immune response, which may affect the liver. We now also have realized in the last 6 months that abnormal coagulation is a very important component of COVID disease, and it may affect the liver as well. And finally, there may be hepatic hypoxemia and reperfusion injury in the liver. We should not also forget that an individual may have pre-existing chronic liver disease, which may behave differently when COVID infection takes place. And some of the drugs used for the treatment of COVID may also cause liver injury. Everybody now realizes that it is ACE2 receptors which are responsible for binding of the COVID virus through its spike protein onto the healthy cells, and then it enters the healthy cell and replicates there. While ACE2 receptors are prominent in alveolar cells, they're also present in other organs, and this includes the liver. In the liver, they are predominantly in the bile duct epithelium, which is called cholangiocytes, but they're also available in the hepatocytes and to some extent in the sinusoidal cell. So these red dots are ACE receptors, which are predominantly in cholangiocytes, but also present to some extent in hepatocytes and also in sinusoidal cells. In addition, liver may be affected by the entry of these viruses inside the liver through other receptors, and some of them which has been recognized are CD147, L-sign, and there's a mechanism of non-neutralizing antibody which may attach to the virus, and then this antibody may, through the help of some receptors, enter the cell. So what happens to an individual who gets COVID infection? What can be the liver disorder? These are some of the pathological changes which may happen, but let's look into the clinical aspects. As many as 14 to 53% in the various cities have been found to have abnormal liver function test, and AST is usually more than ALT. We must realize that these enzymes may also be elevated because of other organs, which can be myositis, myocardial injury, hypoxia, and because of the medicines. It's rare that these enzymes are very high in the terms of thousands and lead to liver failure. Less commonly, the other enzymes may be affected, which includes alkaline phosphatase and gamma GT. And this is not surprising, knowing that biliary epithelium has maximum concentration of ACE2 receptors. It has been found that severe COVID patients are more likely to have liver dysfunction. There is also a belief that those who have liver dysfunction and having COVID are more likely to die, but this is somewhat debatable. So let's now move to those patients who have pre-existing liver disease. What are the risks of COVID in these individuals? This is how a normal liver looks like, cirrhotic liver. We know that non-alcoholic fatty liver disease patients may be more prone to severe COVID disease, as often this is a part of the metabolic syndrome. So NFLD we know because it can be a part of metabolic syndrome with association of with diabetes mellitus, obesity, and hypertension. And because of these factors, NFLD patients are more likely to have severe COVID disease. Primary sclerosing cholangitis and primary biliary cirrhosis, because again, this is the disease of the bile duct epithelium, may have deterioration because of the COVID. There is no data that autoimmune hepatitis, another chronic disease, have any increased risk, and this is in spite of their being immunosuppressed. We all know that decompensated liver disease patients may be more prone to COVID disease because of immunocompromised status. Now, there are two registries, global registries. In fact, there are 3 global registries which are collecting data on pre-existing liver disease developing COVID. And collectively, they have about 1,500 patients, which is collected over a period of 1 year, 726 with cirrhosis, and 259 with liver transplant recipients. So this is data from 150 centers from 30 countries, and the numbers are gradually increasing. Now, if you look at the component of this data, as I said, 35 countries contributing to these submissions, 508 cirrhotics, various etiologies I mentioned here. 88% of them were hospitalized, 27% were required intensive care, and 31% died. Among the non-cirrhotic, the risk is somewhat lower. Again, hospitalized were 82%, but death rate was only 7%. In the liver transplant group, hospitalization was 81% and death was 18%. Now, if you look at this study, which has been published recently involving almost 1,300 patients with pre-existing chronic liver disease, and they have 4 groups: CLD without cirrhosis, those with mild, moderate, and severe cirrhosis. And you look at the hospitalization rate is almost similar. But in severe disease, there were more chance of ICU admission, a little more chance of ventilation requirement, obviously a high risk of death compared to less severe cirrhosis and non-cirrhotic. And this shows the case fatality rate. So even in the younger group patients, the case fatality rate in cirrhotics was higher than non-cirrhotics. So in general, if I have to summarize, mortality in cirrhotics is somewhat higher, 32% compared to non-cirrhotic 8%. It is related to child score. Worse the child score, worse the cirrhosis mortality. Alcoholic etiology is somewhat higher mortality, but we must realize that even in cirrhotic patients, 71% die because of respiratory failure rather than directly to the liver disease. Now, if you look at this group without cirrhosis and with cirrhosis, look at the hospitalization rate is similar. The ventilation rate is also similar, but the death rate, here it is 8%, and in cirrhotics is 32%. But this is Indian data. In fact, Asia-Pacific data. On 228 patients with liver disease, cirrhosis 43, non-cirrhotic 185. Just look at these 2 charts. As the cirrhosis progresses from compensated to non-compensated, the severity increases and the mortality also increases. So in general, child-to score of more than 9 means the mortality rate is higher. Now, this is an interesting chart which shows the mortality in chronic liver disease if they are hospitalized. Without cirrhosis, the mortality is 8%. With severe cirrhosis, it is 54%. If they are admitted to the ICU, without cirrhosis, 20%. With severe liver disease, it's 79%. If they receive ventilation, without cirrhosis, 21%. And with advanced cirrhosis, almost 90%. Now, there's a crosstalk between liver and lung. So even in cirrhotic patients, because of systemic inflammation which they have, because of acute hepatic decompensation, because of decreased T lymphocyte frequency and proliferation, because of B lymphocyte frequency, and because of decreased CD24 memory cells, it all affects the various defense mechanisms, leads to hypercoagulation, ascites encephalopathy, decreased antigen-dependent responses, and defective vaccine response. All of them contribute to respiratory failure, which is usually the cause of death in these patients. What about COVID-related acute on chronic liver failure? This is a small study on 20 patients from Delhi, and this behaves like cytokine storm and leads to prolonged hospital stay, severe COVID illness, need for ICU, and a very high mortality, 30%, compared to those without COVID ACLF. What about liver transplant? Obviously, the liver transplant number have come down because of logistic reasons, because of the safety reasons. But then we are primarily doing it where the indications is super urgent. And we are still using the cadaver transplant, provided the cadaver itself, the patient does not, the donor does not have COVID. So this is the data on 151 transplant. Look at hospitalization rate is the same. Requirement of intensive care is the same. ICU admission, however, was higher in the patients who are liver transplant recipient. Invasive ventilation requirement was higher, though fortunately the mortality rate, there was no difference between comparative cohorts and the liver transplant. And this is a case fatality rate. Again, you look at the younger population, the case fatality rate in liver transplant group is somewhat higher, but with the advancing age, it's the age which decides the case fatality ratio. Lastly, we must not forget that COVID drugs can cause liver dysfunction, and I have just encircled 4 of them here. Azithromycin is a commonly used antibiotic. Remdesivir, we all know, has been used extensively in COVID in spite of not very robust data. Convalescent plasma was extensively used in the first wave of COVID, and baricitinib is a new drug which has been tried in COVID. All of them are potentially hepatotoxic and therefore should be avoided in presence of liver dysfunction of significant degree. And if you are giving them, you should closely monitor them. What about interventions and endoscopy in patient liver disease? I think urgent indications like varicose bleed or cholangitis, one has to do endoscopic intervention. But as you go down in my list, the indications become less and less urgent, particularly when there is a patient who requires an ERCP for just an obstructive jaundice or CVD stone. One may wait for a few weeks, and surveillance for varices should be deferred in the present situation. However, this protocol will depend on whether the healthcare workers have been vaccinated completely and on the triaging and safety factors of your setup. Lastly, what about vaccination for patient with liver disease? You must prioritize patient with liver disease, particularly those who have cirrhosis, those who have malignancy, those who are awaiting liver transplant or post-liver transplant. The vaccination should be given because we have, as we discussed till now, these patients have high risk of decompensation and mortality. However, there is concern that the protective response in these patients may be suboptimal, and we do not have safety data in children with CLD. So whether they should be vaccinated, we yet do not have the final answer. Thank you very much.